Hi, welcome back. In this video, we will be brushing through hypertension, and I hope it makes it easier to understand with all the visuals that I put up. When you hear someone say, I have high blood pressure, what do they mean? Blood pressure is the force of blood against the walls of the arteries. High blood pressure is anything higher than the normal range, which is less than 120 over less than 80 millimeters of mercury in adults. Hypertension is diagnosed if the blood pressure reading is equal to or greater than 130 over 80 millimeters of mercury. A diagnosis of high blood pressure is usually based on an average of two or more readings taken on separate occasions. That's another exam question. How do we diagnose hypertension? Usually, it's two or more readings, blood pressure readings taken on separate occasions, not just one random blood pressure and you say this person has hypertension. They could be having elevated blood pressure, but they're not hypertensive. They do not have a diagnosis yet. What is this process is also known as silent killer. That would be hypertension. And which is the most common type of hypertension? Essential or primary hypertension? Another exam question there. Essential or primary hypertension is what most people are diagnosed with. It has no single cause that you can point out and say that this person has hypertension because of this. It just creeps up on them. The second type of hypertension is secondary hypertension. This is when somebody gets diagnosed with hypertension and the cause is usually secondary to something else, let's say kidney disease, maybe endocrine disorder or sleep apnea, or they've been using steroids for so many years and so now they get the diagnosis of hypertension. Risk factors of hypertension. We have non-modifiable risk and modifiable risks. What's the difference? Non-modifiable risks are factors which means there is nothing we can do to change them. They are they just happen, you happen to be there and there's nothing you can do about it. This includes your age. So as we grow older, our arteries stiffen and calcifies, and because of that, they become non-compliant or less compliant, and we are more likely to have higher elevated blood pressures than someone who's younger. Family history is another non-modifiable risk, genetics, race. Hypertension is highly prevalent among Black and Hispanic adults compared to other races. Modifiable risk factors. These are risk factors that are within our own control, so we can do something about it and make a turnaround. Include our diet, our weight and obesity, our lifestyle. Like if you are inactive, you're not working out, you're not active at all. Alcohol, smoking, use of nicotine, high stress levels like nursing school, and poor sleep like nursing school, sleep apnea, and night shifters. If you've been doing night shift for many years, you are at very high risk of getting diagnosed with hypertension. Of course, also using medications like steroids or antidepressants for so long, you can end up getting hypertension. Signs and symptoms of hypertension. Most people have no symptoms even with dangerously high levels. Then that's why we say hypertension is a silent killer. It creeps up on you because you don't know that you're hypertensive until you get to the end stage where now you're in hypertensive emergency. So when symptoms do occur, usually these patients will probably be in hypertensive emergency, whereby there's identified target organ damage and they feel something is wrong, and so they rush up to the emergency room, or they start having stroke symptoms and they call 911, and that's how they find out. Before we talk about the signs and symptoms of hypertensive emergency, let's differentiate between hypertensive urgency and hypertensive emergency. So, based on the stages of hypertension, a patient is considered to be in hypertensive crisis when their blood pressure is greater than or equal to 180 over 120 millimeters of mercury. Hypertensive crisis has two types. So, if your patient comes in, you take their blood pressure, systolic is let's say 190 and diastolic is let's say 122. They are in a hypertensive crisis, but is it urgent or emergent? Hypertensive urgency, which means Even though their blood pressure is that high, they do not show any signs or symptoms of target organ damage. Most patients who come in with this, they're usually because they randomly took a blood pressure reading at home and it was really high, or they were at their doctor's office and for checkup, and so they're going there for something else altogether. And so the doctor had to send them to the emergency room because their blood pressure was really high, like 200 systolic. And then there's hypertensive emergency. Just like this name says, it's an emergent situation because the patient will present with signs and symptoms of organ damage, such as stroke. Stroke is damage going on in the brain. They'll have stroke-like symptoms like slurred speech, weakness, severe headache, confusion, altered mental status, nosebleeds, chest pain or myocardial infarction, that's damage to the heart muscles, shortness of breath, damage to the kidney, elevated BUN, creatinine, decreased urine output, and then damage to the retinal vessels that can cause vision changes or blurry vision. And for pregnant women, usually they may present with seizures or eclampsia. So, um, usually in an exam question, they tell you this patient came in, their blood pressure is this, let's say 185 over 126, and they have decreased urine output and blah, 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 blah. So, and they want you to tell if, are they in a hypertensive crisis? Yes. Are they in hypertensive urgency or hypertensive emergency? They're in emergency because they have an organ that is showing signs and symptoms of damage, and that's decreased urine output. Complications of untreated hypertension could be stroke, myocardial infarction, heart failure because now the heart has to pump against a really high systemic vascular resistance or afterload, the force against which the heart has to pump against to push blood out into the arterial system. Other complications could be chronic kidney disease from high blood pressure bumping onto that kidney for so many years, peripheral arterial disease, hypertensive retinopathy, that high blood pressure bounding and pounding on the retinal, the tiny retinal vessels, and so it damages them and they bleed out. Arterial fibrillation from just dilated heart and heart that has been overworking, cognitive decline like vascular dementia from over time having those a lot of inflammation going on or cerebral encephalopathy from that high blood pressure just pounding on the blood vessels in the brain. How do we diagnose hypertension? First thing is taking blood pressure readings. Hypertension is diagnosed with a blood pressure reading that is equal to or greater than 130 over 80 millimeters of mercury. A diagnosis of high blood pressure is usually based on average of 2 or more readings taken on separate occasions. Again, that's an exam question right there. Additional diagnostics, we can do lab work to see how they're doing, their fasting blood glucose, their lipid panel. We're just trying to see what are the risk factors and what could have caused this high blood pressure. Kidney evaluation like BUN, creatinine, urinalysis, just to see is it the kidney that failure that is causing this hypertension, or is it that hypertension injured the kidney and now we have elevated BUN creatinine. Endocrine tests, if secondary to hypertension, suspected from, like, let's say, hyperparathyroidism or Cushing's disease, hyperthyroidism. EKG for left ventricular hypertrophy due to the increased afterload systemic vascular resistance that it has to push against, or arrhythmias. Also, ambulatory blood pressure monitoring can be used for white coat syndrome. So, what is white coat syndrome? This is where someone or some people have a phobia for healthcare settings, and so automatically their body goes into fight or flight mode when they're in a hospital setting. Their blood pressure goes skyrocketing high, and once they leave the vicinity, they get back to normal. Ambulatory blood pressure monitoring can be useful to rule out this. So you don't just conclude this person is hypertensive because I just took 2 readings, and if you suspect they could be having white coat syndrome, they could be sent home with the ambulatory blood pressure monitoring. You have your cuff around your arm and you walk around with it throughout the day, and randomly the cuff will take blood pressure on you, and they will look at it over time and see if you've been consistently high or it's just some situations where you have high blood pressure and some you're fine. This might sound silly, but you will see in an exam question asking if you know how to measure the blood pressure correctly. So before you take any blood pressure reading on a patient, first things first, prepare the patient, have them sit quietly for 5 minutes. Feet flat on the floor, legs uncrossed, back supported, and also have the arm at the heart level. This is just so that you don't get an off reading, false high reading. Ensure they've asked them if they've, within the last 30 minutes, if they have had caffeine in the form of coffee, tea, nicotine, alcohol, or maybe they've been involved in some exercise or physical activity that would increase their heart rate and, of course, their blood pressure within the last 30 minutes. If so, then they need more time to relax, and then you can take a blood pressure, because then you don't want to get a falsely elevated blood pressure. Also ask them if they need to empty their bladder. A full bladder can raise the blood pressure by 10 to 15 millimeters of mercury. Have them remove any tight clothing from the arm you will use to take the blood pressure. Choose the correct cuff. Very important, because the wrong size can throw off your reading. The cuff bladder should cover the arm, 80% of the arm circumference. 80% of the cuff bladder should wrap around 80% and cover 80% of the arm circumference. Too small of a cuff will lead to falsely high blood pressures. Too large of a cuff will give you falsely low blood pressures. Positioning. Arm should be relaxed. The palm should be facing up, supported on a table, heart level. The cuff should be placed on bare skin, not over clothing. Ensure the cuff's artery marker aligns with the brachial artery. Measurement. Use a validated automatic blood pressure machine if you have to use one. Take 2 readings 1 minute apart if you have to. So if you need to repeat a reading, for example, if the first reading you get is extremely high or extremely low and you doubt if this is correct, you need to repeat, but you have to wait 1 minute in between each reading. And rule of thumb is that if you use an automatic blood pressure machine and it gives you a really drastic number, you should repeat it with a manual cuff, not repeat with the same machine. You repeat it with a manual cuff. You'll see that in an exam. Treatment for hypertension. The first line treatment for any stage of hypertension and for all patients is lifestyle modification. That's the first line. That's another exam question there. The first line treatment for all types of hypertension is lifestyle modification. Eating healthy diet, low sodium, healthy fats, weight loss, regular exercise helps the blood pressure to come down. Limit alcohol, stop smoking, managing stress, those things that cause blood pressure to get elevated. And if you're using medications like steroids, they probably have to discontinue them or find other ways. Medications common that can be given. So medications they start giving you if the lifestyle modifications are not helping, or if maybe you are way up in hypertensive crisis during the first diagnosis. So of course you have to be given medication alongside lifestyle modifications. So they can use diuretics like thiazides, they can use antihypertensives like ACE inhibitors, angiotensin receptor blockers, those are the ARBs. Calcium channel blockers like the amlodipine, beta blockers can be given, but they're usually not first line. Beta blockers they give like if you have comorbidities like CKD or diabetes or heart failure. So yeah. Nursing considerations, assessment. Ensure proper blood pressure technique is being done when you're taking your blood pressure readings on your patient. You remember the resting 5 minutes, rest arm, calf, that mnemonic. Calf quiet, rest arm, calf quiet. So rest for 5 minutes, have your patient rest when they get in. Make sure you ask them if they've been exposed to anything that would stimulate them and throw off their blood pressure, like having coffee, any sort of caffeine, alcohol, they've been running, or they have a full bladder. The arm should be at heart level. Assess for symptoms of hypertensive emergency. Monitor for medication side effects. Most antihypertensive, of course, they share some side effects like orthostatic hypotension, electrolyte changes. Interventions. First things first, elevate head of the bed or have them sit up straight. This helps reduce pressure of blood rushing to the brain. When someone is hypertensive, have them sit up. Do not lie them flat. When they're hypotensive is when they sit flat so that, or they can also raise their feet up so that blood can rush back to the heart. But in this case, it's hypertensive. So we sit them up, raise the head of the bed. This protects the brain cells. Administer antihypertensives as ordered. Recheck blood pressure after medication administration so that you're not, dropping that blood pressure drastically. Monitor ins and outs, daily weights, especially with diuretics. Educate on lifestyle modifications. Encourage home blood pressure monitoring and keeping a log. Evaluate adherence and barriers to taking medications. It could be maybe it's expensive, they cannot afford it. Side effects of medication like ACE inhibitors, some patients are just uncomfortable because they give them this cough that does not go away, and it's really messes up with their lifestyle, so they might stop taking medication. So for that case, they can let the doctor know if you feel you have a cough that does not go away, they may need to switch them to another blood pressure medication. Patient education. Hypertension is often asymptomatic. Importance of consistent treatment. So remind them that they need to come and follow up checkups and all that. Avoid steroids and other medications that will increase or will expose them to a elevated blood pressure, even decongestants. Do not stop medications abruptly. Antihypertensive, those are the one of the medications that we do not stop abruptly because they will have a rebound hypertension. Teach them when to seek emergency care when they have severe headache, chest pain, visual changes, and so on and so forth. For hypertensive emergency, do continuous cardiac monitoring for this patient. You can give IV antihypertensive like nicardipine, labetalol, frequent blood pressure checks, avoid rapid blood pressure drops. If a patient comes in with a really elevated blood pressure, we do not want to drop it like they are in 200 systolic and then you give them medication and then all of a sudden you want them to be in 110 over. No. Sudden drops in blood pressure can cause sudden low perfusion, risking brain ischemia, stroke, kidney damage, and other organs. So we have to bring them down, land that plane low and slow. So we reduce the mean arterial pressure by no more than 25% in the first hour of treating this hypertensive emergency or crisis. So remember, land that plane low and slow. Thank you for watching, guys. If you find my content helpful, kindly support my channel by liking, subscriptions, and sharing my content. I'm so grateful if you have done so. Otherwise, I'll keep on creating more content, and I'm motivated knowing that it's helping someone on the other side of my screen. So see you on the next one, and bye for now.